Hi, Mariah. Are you ready for rounds?
Hey guys, yeah, I am.
Great.
Etiquette-based medicine demonstrates respect and should be part of all patient interactions. Use the patient's preferred name and title when known, sit at the patient's eye level, and perform each step of AIDIT during the visit. AIDIT stems from UW Medicine's Patients First principles and is a tool designed to enhance overall patient satisfaction. The acronym AIDIT stands for Acknowledge, Introduce, Duration, Explanation, Thank. Acknowledge the patient and all others in the room. Introduce yourself, your skill set, your professional or training credentials, and years of service. Duration. Explain how long rounds will take. Explanation. Help patients or family members understand what they should expect and what may be expected of them. Thank. Close rounds with an expression of thanks or hope.
Good morning, Jim. Hello, Monica. I'm Jesse Aberclafter. I'm the senior resident on the medicine team, with the primary team taking care of you and coordinating all your care. Is it okay if we come in and chat?
Sure.
So this is Anna, the intern on the team. This is Tomio, our medical student. Grace, our pharmacist. Dr. Krug, the supervising physician. And Mariah, the nurse. Anna's going to present the formal plan briefly, and then we're going to summarize it for you. Dr. Krug may modify the plan a bit. We'll do a quick exam, and we'll be on our way.
Mr. Smith, do you mind if I turn off the TV for just a moment?
Sure, that's fine.
Agenda setting with the patient and family is essential for efficiency. New issues should have already been solicited during pre-rounds. Politely indicate to the patient and family members that you'd like them to hold their questions until the end of the presentation rather than interrupting. The presenter should be as concise as possible. Reading notes verbatim can lengthen presentations unnecessarily. It may be easiest to review and put away notes while presenting the patient, referencing the CORS list or other notes only when needed. The chief complaint should orient the listeners to the active problems and diagnoses, not just clinical symptoms. The presentation should focus on relevant symptoms and rhythm of illness.
Okay, so Jim is a 58-year-old man with past medical history of cirrhosis who is admitted with SVP and acute kidney injury. This morning on pre-rounds, Jim described some worsened abdominal pain that's especially worse with movement. Mariah, would you be able to review the overnight events and the recent data?
Sure. So he had a low urine output overnight with a systolic blood pressure in the 80s. He received a 500 milliliter IV bolus. Current vitals are temperature 38.2, Tmax 38.6 at midnight. BP is 96/55, heart rate 65, respiratory rate 18. His pain is a 6 out of 10, and he used 4 doses of oxycodone 5 milligrams in the last 24 hours. Weight is 74 kilograms. Ins and outs were 3,200 and 650 of urine. 6 BMs in the last 24 hours. He's oriented to self and to place, but sometimes forgets the date. One person assists to the bedside commode, and he'd like to know if he could have a higher dose of oxycodone.
Thank you so much, and we will definitely talk about your pain control when we go through the assessment and plan.
Rather than reciting all data, present only key exam findings and labs. Other team members should be attentive and save interruptions to the end as much as possible. The presenter should use the assessment and plan to focus on active problems, plans, and questions.
Any new radiology data to discuss this morning? So, assessment and plan. Jim is a 58-year-old gentleman with a history of cirrhosis who is admitted with SVP and acute kidney injury. His creatinine has been worsening, and his encephalopathy is continuing despite aggressive treatment with lactulose. So the plan for his SVP, it's currently stable. We're treating him with cefotaxime.
The presenter addresses any concerns raised by the patient or RN. Be aware of what content the nurse will present in the checklist to avoid duplication.
Kidney function, but I think we can tentatively plan for discharge on Monday. His code status is full code. Mariah, would you be able to go over the quality checklist with us?
Sure. So his skin continues to be at risk. He has a stage 1 sacral pressure ulcer, which is being treated with barrier cream. I would recommend a low air loss bed as well as a wound care consult. He's being treated.
Some recommendations can be very quickly highlighted in the SBAR format. although this need not be used for all elements of the quality checklist.
That was placed 2 days ago. The situation with his Foley catheter is that it was placed 4 days ago. The background is that he was much more confused when that was placed. My assessment is that he could, at this point, we could help him to the bedside commode, or he could be helped to use a urinal. So my recommendation would be that we remove the Foley catheter.
Thank you so much. Those are all great points. I definitely agree that we should try to remove the Foley today. I will put in an order for that. Mariah, would you be able to call the wound care team to place a consult and text page me if they recommend the low air loss bed?
So Dr. Fay will put an order in to remove the Foley. I will call for the wound care consult.
Great.
Foley removal.
The nurse should help the team to update the whiteboard, which serves as an essential patient communication tool.
Is there anything else that I could add here to make this more complete?
Yeah, could we put there that he's going to continue to get IV antibiotics, and we're going to have him work with physical therapy? Jim and Monica, could I just summarize the plan for you?
Yes, please.
We're continuing to treat the infection in your belly with IV antibiotics, and we're going to follow up on the cultures of the fluid we took from your belly to make sure we're using the right antibiotics. Unfortunately, your kidney function is still continuing to get a little bit worse. We're continuing the IV medications for that, but we're just going to have to continue to closely monitor you over the next few days. Now, in terms of pain control, I'm really glad that your confusion's been getting less over the past few days, and I'm concerned that increasing the oxycodone could make you more confused. I really want to develop a safe plan to control your pain. I was hoping we could start with Tylenol today, schedule that over the course of today, and see how that does in controlling your pain. Is that all right with you?
Okay, sure.
Great. The other thing we were mentioning was that we're hopeful that you can be discharged on Monday, but we're just going to have to see how your kidney function does between now and then. And as we said, we're going to have you work with our physical therapists and occupational therapists. I'm hopeful that you'll be able to go home, but it's possible that you'll still be a bit weak. At that point, you may need to go to a skilled nursing facility. If that's the case, we'll work with you to find the right facility. What questions do you guys have for us?
I don't think I have any right now.
I guess I'd just like to know how to prevent this from happening again.
Sure.
That's a really great question. The short answer is that you'll need to take an antibiotic every day, but I'd like to come back later to learn what you know about cirrhosis, if that's okay with you.
That'd be great.
Great. Thank you both so much for participating in rounds with us this morning. I'll swing by a bit later so we can talk.
Thank you.
Thank you, team. I have no corrections or additions to today's plan. Mariah, thank you very much for your portion of the presentation. We're going to do a physical examination and then go over a few brief teaching points. You're welcome to stay for that, or you can go if you need to go.
I appreciate the offer, but I should attend to my other patients. I'll see you later with your 9 a.m. meds.
All right, thanks, all right.
You're welcome.